I don't usually win, so I feel very accomplished today. Okay. So, before we start lecture today, I have a question for you all. I hear through the grapevine that you have an exam late this week and an exam early next week. How would you like to push the exam early next week back a day?
Yeah.
Anyone opposed? No. Okay, so.
No.
So exam, it will be next Tuesday instead of on Monday. Monday we will start the head and neck, but that material will not be on the exam. So that gives you an extra day to study. That's good? Thank you. You're welcome.
Seriously? So it's Tuesday now. So it'll be Tuesday.
Oh, that's not a test. That's just a...
Okay, so let's keep marching down the upper limb, working through. So last time we talked about the branches and the segments of the brachial plexus. And so now we're coming towards the end of it, and I'm going to try this, see if I can do it. Does it do it on screen? It does. So much fun. I know. I'm getting fancy here. Okay, so you can actually see it. And I figured out that it was exporting the PDFs from my, what's it called, Keynote, that was causing the problems. So I just saved it as a PDF and it's all fine for the letters and everything. So technology has been good to me this week.
Good. Don't jinx it.
I'll try not to, knock on wood. Okay, so a couple of things here. One anatomical feature that really helps out with identifying where you are in the brachial plexus is this M structure. I don't know if Cassandra showed you that in lab. I'm going to obliterate the picture of the nerves, but this M formed by the musculocutaneous nerve, the ulnar nerve, and the median nerve. And then there's a trunk that's going over from between the ulnar nerve and the median nerve. So that M structure can kind of help you figure out where you are in the brachial plexus and what everything is. Okay. Going down from there, the musculocutaneous nerve continues down the anterior portion of the arm, eventually innervates the anterior compartment. The median nerve and the ulnar nerve travel down alongside the axillary artery. This is really big. There we go. So along the axillary artery on either side. Okay. That was really fun. Okay, so radial nerve, we can't see on this. We have to pull the axillary artery out because the radial nerve runs along the posterior surface of the axillary artery. And so here it is right here. And then dives into the posterior compartment through this aperture here. Does anybody remember what that aperture is called? Triangular interval. Triangular interval. Mm-hmm. Okay. All right, another one to point out on this slide is, remember I talked last period about the subscapular nerves? Here's a diagram that actually shows you them. So this is pertaining to last lecture. All right, and the axillary nerve you see taking off and heading to the posterior portion of the shoulder joint, coming up off of the radial nerve up higher. Okay. All right, bless you. All right, lymph nodes. So several different batches of lymph nodes that you need to know. The pectoral nodes, we've seen them before. We were talking about the pectoral region. That's what they drain. The humeral nodes drain the upper limb. And then the subscapular nodes drain the scapular region. Okay. All of those then feed into the central node. Central nodes here. And those then continue up into the apical nodes. You can see kind of the path of lymph flow there. Excuse me. Okay. All right, so that's the axillary region. Now we'll move on to the arm, and we'll start off again with some bone features. So we're going to talk about the bones that make up the elbow joint, even though we're not going to talk about the elbow joint proper at the moment, just because we have muscle attachments that go across that elbow joint when we're talking about the arm. So a few things I want you to know, and these are things you're learning in lab already, so it should be easy. Just learned it on a diagram. So we've got the condyle made up of the capitulum and the trochlea. The trochlea would be the location that's we're looking for articulating with the ulna, and then the capitulum would be articulating with the radius. Okay. Then we have our medial and lateral epicondyles, which are, of course, are important muscle attachment sites. Okay. That's all you need to know for lecture. I'm sure you have lots more in lab. All right. So the proximal radius, obviously you need to know the head of it, because that's the articulating surface with both the humerus and the ulna. And the radial tuberosity, which is the attachment site for the biceps brachii. And I think on my notes I have the oblique line. Well, I don't think we care about that, so just crash test that one. So in the radiograph, you can see here the epicondyles of the humerus, kind of out on the sides, and then here would be the trochlea and the capitulum there, head of the radius, and then also you've got the proximal ulna right there. Excuse me. All right. Proximal ulna, there's a few features on this that we should be aware of. We have and I'm going to have a hard time pronouncing this word. Anybody want to do it for me? Olecranon. Thank you very much. So that's going to contain the trochlear notch here, which is going to be obviously be the articulation with the trochlea of the humerus. The coronoid process coming out to kind of complete that sort of socket formation. The radial notch, which is articulation with the head of the radius. And then the tuberosity of the ulna, which again, muscle attachment sites. Okay. That's it for the ulna for now. All right, so then we'll go back to our identifying muscles in the compartments of the arm. So our major muscle is obviously the biceps brachii. We have the short and long head. The short head attaches to the coracoid process. The long head attaches to the just above the glenoid cavity. And remember, we have this transverse humeral ligament that keeps the tendon of the humerus within that interturbicular sulcus on the head of the humerus. And then the tendons, here we have the main tendon. What's the word I'm looking for? Inserting on the radial tuberosity, and we also have the bicipital aponeurosis that wraps around the ulna. This will be important when we talk about the cubital fossa. Kind of hiding behind the biceps is the, oh dear, all these words, I'm not going to have a easy time pronouncing them today. Coracobrachialis. Wow. I need to start practicing like in front of a mirror or something. I don't know. So that's going to also attach the coracoid process, and then inserts about mid-shaft on the medial mid-shaft of the humerus here. And then finally our brachialis muscle, which inserts on the tuberosity of the ulna and originates on the humerus. Okay. So the brachialis and the biceps brachii are going to be both working on elbow flexion, obviously. The coracobrachialis and the biceps brachii also involved in flexion of the shoulder joint. Okay, because we've got those branching over the shoulder joint there. Okay. All right, posterior compartment, super easy. The only one that's really of any significance is the triceps brachii. So we need to know, obviously, the lateral head, the long head, and the medial head, and where they all insert, and then also the or where they originate would be the proper term, and then where they insert is on the, this word's gonna drive me nuts, olecranon. Okay, yes, okay, so, and this is obviously extension of the elbow joint. All right, arterial supply of the arm. So obviously things are coming through the axillary artery. At the lower border of the teres major muscle is when we switch over to the brachial artery. And branches up the brachial artery, we will supply the anterior compartment. The profunda brachii artery is going to pass through that triangular, oh gosh, I just said it a few minutes ago. Interval, there we go, triangular interval into the posterior compartment. And then finally, just distal to the elbow, we'll have the division of the brachial artery into the radial and ulnar arteries. So, nice and simple. All right, so here we can see the profunda brachii artery as it wraps around the posterior side of the humerus. It also sits in the radial groove, just like the radial nerve sits in that radial groove there. So it's the potential for damaging that with the mid-shaft fractures there as well, though typically not as commonly done as the radial nerve damage. And I just want you to be aware of the recurrent arteries that supply the elbow joint. So we have radial recurrent arteries and then two ulnar recurrent arteries. So these are all going to be contributing to supply of the elbow joint. All right, vasculature makes sense? It's all good? Yeah, question?
Which compartment did you say the profunda brachial artery supplies?
Posterior compartments. Mm-hmm. Any other questions? Nope. Okay. Oh, here's our pesky veins again. So just a reminder of them, where we have deep veins that follow the profunda brachii artery down into the posterior region. We have the basilic vein coming up from the medial portion of the limb, the cephalic coming up the lateral portion of the limb, and then our paired brachial veins that run on either side of the brachial artery coming up and joining with the basilic here to form the axillary vein. Just remember the reason for paired veins in the extremities right next to a central artery is what? You remember that?
Like temperature.
Mm-hmm. What was the term for that? Do you remember? Heat exchange, yep. So we have two currents running opposite directions. That's our counter current, and then they're passing.
So did you say the arteries run right next to them? Is that what you're saying?
Yeah, so that on
Okay.
each major artery of the limbs, there's going to be paired veins that run right beside it, and that's when we have that heat exchange. Even with the heat exchange, there's about I can be as much of as a 10-degree difference in the temperature of the distal extremity versus the proximal extremity. So it really makes a big difference having, conserving that heat in the proximal extremity, not allowing it to get cooled as much as the distal extremity. Okay. What else was I going to say about this? I can't remember. Oh, right. What is the second reason for having the veins right next to a larger artery?
Like the pulsation of the artery helps
Mhm.
blood move through the veins.
Exactly right. So it's the arteriovenous pump is what they call it, and that helps move the blood through the veins. Excellent. And then we have our valves that prevent backflow as long as it's working properly. All right. So innervation of the anterior compartments, nice and easy. We've got the musculocutaneous nerve, and it's the big head honcho there. The median and ulnar nerves pass through, but they have no major branches. There we go. Okay. So that is the nice simple story of anterior compartment innervation. All right, posterior compartment innervation, also a nice simple story. We have the radial nerve. It sends small branches out to innervate the triceps muscles, and then continues onward down to innervate parts of the forearm and hand. All right, so end of story. Oh wait, not quite. So here's just surface anatomy. So seeing the radial nerve kind of crossing over here. A landmark you can use is just that triceps muscle, the lateral part of, or medial part of the triceps muscle there. As we see the brachial muscle kind of tracking along the edge of that muscle there. Okay. All right, so then, of course, we have to talk about midshaft humeral fractures. So there's 3 basic types of fractures you can have. You can have blunt force, causing a, get my words correct again here. Where it is, transverse fracture, goodness. This is a transverse fracture. And so we've got just a very old, well, I guess transverse is a good example, or good term for it. So transverse fracture across the humerus. If we have a twisting force, that will result in either an oblique fracture or a spiral fracture. This is a spiral fracture here. You can see how it's got a longer region of the humerus that has bone disrupted. Typically the fracture does spiral around it. So either one of these types of fractures obviously can damage the radial nerve. And do you remember from Dr. Carlson's lecture, what was the sign of radial nerve damage? Inability to extend the wrist. Remember what he called that? Wrist drop. Yep. So wrist drop is indicative of that radial nerve damage. Okay. Any questions about humeral fractures? Okay. All right. So elbow joint. So like we said before, we have the trochlear notch or trochlear notch of the ulna articulating with the trochlea of the humerus. The head of the radius articulating with the capitulum of the humerus, and also the radial notch of the ulna. So So, articulations there. Remember, we've got just of the elbow joint itself, just extension and flexion. But then we also can have pronation and supination of the forearm. And remember, the reason we can have that is rotation of that radial head within the radial notch. So it's round surface structure allows that rotation for pronation and supination. All right, to facilitate that rotation of the radius, we have a couple of things. We have the synovial membrane that obviously encapsulates most of the joint, sends a sacciform recess down in between the radial, the head of the radius, and the annular ligament of the radius. And so the annular ligament, it's holding the radius in the radial notch. And then the sacciform recess kind of lubricates between the head of the radius and the annular ligament to allow that radius to rotate freely without too much friction. Okay. Then if we add another layer, obviously we have the fibrous layer, fibrous membrane of the joint capsule, and then like we had in the knee, we have collateral ligaments. So we have the radial and ulnar collateral ligaments. That prevents lateral movement of that joint. Okay. Elbow joint makes sense? All right. So here's a radiograph of an adult elbow joint. So we can see here the trochlear notch coming around here and the coronoid process, the olecranon. Hey, I said it right. That's fun. The radial tuberosity for our biceps brachii attachment. There we go, that's our biceps brachii right there. And then you can see the head of the radius kind of tucked in here beside the ulna. All right. Now, something to be aware of with the elbow joint is the development. So think way back to whenever you last had any developmental biology. For me, that was a very, very long time ago. And long bones typically start out as what? Cartilage, right? And then they slowly become ossified. So that is the case with all of these long bones in the arm. And so though the shafts get ossified fairly early on in development, the condyles and epicondyles and all of that are slower to ossify because we're allowing for more length to be put on that bone, right? And so if there's an elbow injury to a younger patient, then we have to be aware of maybe how much has been ossified, how much of this bone has been ossified, and based on the age of the patient. And that can help us potentially prevent a misdiagnosis of a fracture when maybe there isn't one. So what do I mean here? So at 2 years old, we can start to have some ossification of the capitulum. So you can see beginning ossification right here, this kind of smaller radio-opaque region. And then by the time they hit 5 years old, we're starting to get more ossification of the head of the radius. And here's additional capitulum ossification. 5 to 6 years old, we're starting to get also some ossification of the medial epicondyle. So you're starting to see some extension of the bone here, as well as continuing capitulum and radial head. There we go, radial head ossification. And then finally, by the time we get to 12 years old, we're starting to get ossification of the lateral epicondyle as well, and the olecranon. So here we see those coming in as well. This part becoming more radiopaque, and then you start seeing the lecranon come in. All right. So how does this help? So if you've got, again, like a patient with an injury, say he's a 5 or 6 year old patient, and you see this extra bit of radio opacity right here, if you are not aware of this developmental process in the secondary ossification centers as they're coming in, potentially that could be misdiagnosed as like a chip off of the radius. So being aware of these is important. So here's from Radiopedia. I liked the way they circled each of the secondary ossification centers as they come in. So 2-year-old child, we're seeing capitulum ossification starting. 4, we have the radial head ossifications. What's the word I'm looking for? Center starting, and so on and so forth. Now you will see differences in the ages that they list here. There's quite a bit of difference. So in this Radiopedia article, they showed 2 different sequences of when each of these ossifications starts. And your book showed yet another one. So just be aware that these are different amongst different groups, but the principle is the same. We start getting those secondary ossification centers. Be aware of them, lest you misdiagnose a fracture when there is no fracture. All right, any questions about that?
So it just wouldn't have developed yet? That's what you'd
Right, so
feel like solid bone, so that's why you might confuse it.
Right, so there's these little regions that are starting to become ossified, so we're starting to get solid bone instead of just cartilage,
Yeah.
and so you're starting to see these little patches that you wouldn't normally see, right? And so if you're not aware that those are secondary ossification centers, you might think it's a chip off of the bone or something.
Okay.
Does that make sense?
Yeah.
Okay. Any other questions? Nope. Well, have a good rest of your Tuesday.
Thank you.